As we just said, this next topic is very high yield for the boards because it is the most common cause of amenorrhea. It has lots of other symptoms as well, and quite a complicated pathophysiology, so stay with me. Polycystic ovarian syndrome is an endocrine disorder in which the luteinizing hormone levels are much greater than the FSH levels. A ratio of greater than 3:1 is considered diagnostic. It is associated with insulin resistance and is thought to be due to high insulin levels causing an increase in GnRH pulse frequency, which in turn causes more LH than FSH to be produced. LH is released with greater pulse amplitude and frequency than normal, and it induces the theca cells in the ovaries to make more androgens. Therefore, you get symptoms of hyperandrogenism like hirsutism. This means you get hair in masculine patterns, such as on the chest, face, and trunk. The continuously high luteinizing hormone also suppresses ovulation, so you will get amenorrhea and infertility. In terms of phenotype, polycystic ovarian syndrome is also associated with obesity. What's more is when you have increased androgens from polycystic ovarian syndrome and increased adipose tissue that is converting those androgens to estrogen, you can see increased risk of endometrial cancer from those high estrogens. As you can see from the image here, you get a thickened ovarian capsule and numerous small subcortical cysts. You might want to try to commit this picture to memory, as it is a pretty classic finding in the setting of this disease, and obviously Step 1 loves classic findings. The next image shows the sonographic findings of polycystic ovarian syndrome. Here you can see the hypoechoic cystic spaces, which is the circle on the image. So what causes the cysts in polycystic ovarian syndrome? The cysts occur because the hormone that maintains the follicles, follicle-stimulating hormone, is low. Therefore, the follicles degenerate, leaving you with just cystic spaces. You'll see a string of pearl-type pattern instead of one dominant follicle because you are not getting the normal process of one follicle becoming dominant and then rupturing during ovulation. The treatment of polycystic ovarian syndrome includes weight loss, oral contraceptives, gonadotropin analogs, clomiphene, which is an estrogen partial agonist, spironolactone, which is an aldosterone receptor antagonist, or surgery. Staying on the subject of ovaries, this fact summarizes the different types of ovarian cysts. Most of these cysts are harmless, but they can cause problems such as rupturing, bleeding, or pain, so occasionally these cysts do have to be surgically removed. Follicular cysts are swollen, unruptured Graafian follicles. They are associated with high estrogen states like endometrial hyperplasia. If they rupture during the middle of the menstrual cycle, they can cause pain. What is this called? It's called Mittelschmerz, as we discussed in the Reprophysiology talk. Now, corpus luteum cysts occur when there is hemorrhage into a persistent corpus luteum, which is formed after an egg has been released from a follicle. Remember that this is the part of the ovary that secretes progesterone. Theca-lutein cysts are also called functional cysts, and they occur in the setting of high gonadotropins with ovulation. They are often bilateral and can be associated with choriocarcinomas and moles. Hemorrhagic cysts occur when a blood vessel ruptures, leading to retention of blood in the cyst. These usually self-resolve and are of little concern. Dermoid cysts actually represent one type of mature teratoma, a name for a type of neoplasm that contains tissues derived from multiple germ layers. Since they're derived from multiple germ layers, they can contain many different types of mature tissue, but more on that in a bit. Chocolate cysts, also known as endometrioid cysts, are the blood-filled cysts in ovarian endometriosis. They get larger during menses due to cyclical bleeding. So again, here's that example of a chocolate cyst from a few months ago. Now for the flash quiz. What are the two conditions that theca-lutein cysts are frequently associated? Choriocarcinoma, hydatidiform mole. So theca-lutein cysts are commonly bilateral, and they're frequently associated with choriocarcinoma and hydatidiform mole. Now for ovarian neoplasms, nascent adnexal masses in postmenopausal women are ovarian cancers until proven otherwise. Now, common gene mutations associated with ovarian neoplasms are BRCA1, BRCA2, and HNPCC. HNPCC tends to be the one that most students forget. Sometimes they'll mention a patient who has colon cancer, and then they'll ask what gene mutation could possibly confer an ovarian neoplasm in this patient. And the answer would be HNPCC. So regarding benign ovarian neoplasms, serous cystadenoma is one of the most common ones tested, and you need to know that it has fallopian tube-like epithelium. Okay, so the USMLE really likes that detail for some reason. It's simple, and just memorize it. Okay, so serous cystadenoma has fallopian tube-like epithelium, which the question will just say that explicitly in the vignette. Another important detail is that serous cystadenoma is frequently bilateral. So the USMLE also likes to assess which cancers are bilateral, such as serous cystadenoma of the ovary or lobular carcinoma of the breast, for instance. These are just small details in the vignette that will help give away what cancer they're talking about. So mucinous cystadenoma, the important detail regarding this is that it has intestine-like epithelium. Okay? So whereas serous cystadenoma was bilateral with fallopian tube-like epithelium, mucinous cystadenoma is intestine-like in terms of its epithelium, and it's multilocular. So it has these multiple cyst-like structures, whereas serous cystadenoma tends to be more uniform in its appearance. So multilocular and intestine-like epithelium are terms that are usually explicated within the vignette itself. They'll just say those details for you. So mucinous cystadenoma, and it's not bilateral like serous cystadenoma is. So mature cystic teratoma is also known as a dermoid cyst, and this tends to be pretty easily described in vignettes where they'll mention characteristics such as skin, teeth, hair, and they'll show you a classic picture similar to the one seen here. Relatively straightforward. A teratoma means that it's a tumor with growths from multiple germ layers. So you might have ecto, meso, and endodermal characteristics of the tumor. Now, the USMLE also loves struma ovarii, which is a thyroid hormone-producing tumor. So if they ever give you a vignette that suggests hyperthyroidism, so if they mention diarrhea or palpitations, sweating, any signs of hyperthyroid state, and they're relating it to ovarian pathology, you know the answer is struma ovarii, which is triiodothyronine or thyroxine producing, which would be T3, T4 respectively. Now a Brenner tumor, the USMLE loves to assess this one as having bladder-like epithelium. So bladder/bladder-like epithelium, which would be transitional epithelium. And less commonly, they'll also mention coffee bean nuclei or a yellow-tan gross appearance. Now, the transitional cell aspect, or the bladder/bladder-like epithelium aspect, tends to be the highest yield detail that they'll mention in questions regarding Brenner tumor. And this will pretty much show up in all Brenner tumor questions. Whereas the coffee bean nuclei, or the yellow-tan gross appearance, tends to be a little bit more rare, but can help you clinch the diagnosis if for some reason you weren't 100% sure. Now, ovarian fibromas, apart from the fact that they have fibroblasts on biopsy, Meigs syndrome is classically the triad of ovarian fibroma, ascites, and pleural effusion. Pleural effusion can characteristically be right-sided, but that detail isn't necessarily so important for step one. But just be aware that the triad of ascites, pleural effusion, and ovarian neoplasm is Meigs syndrome, and the ovarian neoplasm is usually a fibroma. So we also have thecomas, which are similar to granulosa cell tumors. Now, recall that our theca cells of the ovary are the ones that respond to luteinizing hormone and produce androgens. So thecomas, these theca cell tumors, will classically secrete androgens. And they're similar to granulosa tumors. Granulosa tumors classically secreting estrogens because the granulosa cells are the ones with aromatase. Now for the flash quiz, histologically, which ovarian neoplasm has fallopian tube-like epithelium? And the answer is serous cystadenoma. Recall that serous cystadenoma has fallopian tube-like epithelium, and it's classically bilateral. So for malignant ovarian neoplasms, we have an immature teratoma. Now, recall that we had a dermoid cyst prior for benign ovarian neoplasms. So a dermoid cyst had hair, teeth, skin, for instance. Now, these are differentiated tissues. These are tissues that have purpose, that have function. So the more differentiated something is, the more benign it is. So the more undifferentiated it is, the more malignant potential it has, because the less purpose that tissue has. So it's more in disarray. Anaplastic is also a word that refers to lack of differentiation, not to be confused with aplastic. Aplastic would be lack of growth, whereas anaplastic just refers to immature characteristic or immature growth. So primitive would be the opposite of mature. So mature teratoma tends to be benign. It's well differentiated, whereas primitive is immature. It's undifferentiated. So undifferentiated, anaplastic, primitive, these are terms that you will see in USMLE questions that should just immediately make you think malignant. Okay? So these terms are synonymous with malignant on USMLE, and immature teratomas therefore tend to be malignant. Now, granulosa cell tumor is most commonly estrogen secreting. Now, as we've discussed, a theca cell is where the androgens are produced. The LH acts on theca cells to produce the androgens, and the androgens move into the granulosa cells, which are high in aromatase, which therefore convert the androgens to estrogens. So granulosa cell tumors predominantly secrete estrogen. They can secrete other hormones as well, but they're most commonly estrogen secreting when you see them in questions. And another detail regarding granulosa cell tumors is that they have Call-Exner bodies, which literally will be described in a USMLE question as these eosinophilic aggregates or eosinophilic secretions. Okay, so these red or pink amorphous type secretions is how you'll see histologically granulosa cell tumors. Now, serous cystadenocarbcinoma is one of the most common ovarian malignant neoplasms, and like serous cystadenoma, which was the benign variant, it's bilateral. Okay, so serous cystadenoma, the benign variant, and serous cystadenocarbcinoma, the malignant variant, are both bilateral, and it's very important you know that serous cystadenocarbcinoma has psammoma bodies, which are these lamellated or onion skin appearing calcifications on biopsy. This is in contrast to serous cystadenoma, which does not have psammoma bodies. And that's a common point that is mistaken with students, is that they'll memorize psammoma bodies for serous cystadenocarbcinoma, and then they'll assume that they're also in serous cystadenoma, but they're not. So the fallopian tube-like epithelium is what you see for serous cystadenoma, but the psammoma bodies is what you'll see for serous cystadenocarbcinoma. Now, can you recall offhand which other tumors/cancers have psammoma bodies? Serous cystadenocarbcinoma, and we also have meningioma and mesothelioma and papillary thyroid carcinoma. Okay, so these four have psammoma bodies. Occasionally, they'll mention one cancer with a psammoma body, such as a meningioma, and then they'll ask you for the other cancer or the other tumor in the answer choice that is similar histologically, and you would know meningioma, serous cystadenocarbcinoma, mesothelioma, and papillary thyroid carcinoma all have psammoma bodies. So mucinous cystadenocarbcinoma would be the malignant variant of mucinous cystadenoma, whereas mucinous cystadenoma had intestine-like epithelium and is multilocular. You can occasionally see that multilocular detail for mucinous cystadenocarbcinoma. That word locular you should have as a synonym with mucinous cystadenoma or mucinous cystadenocarbcinoma. But one important detail that will give away mucinous cystadenocarbcinoma in a USMLE question is pseudomyxoma peritoni, which is the accumulation of mucinous material in the peritoneal cavity. Okay, so it's either you've heard of it or you haven't. This isn't something you have to think too hard about. It's that you've learned it or you haven't. So the accumulation of mucinous material, okay, the accumulation of mucus in the peritoneum is called pseudomyxoma peritoni, and you can see it with appendiceal tumors. You tend to see it with mucinous cystadenocarcinoma. Fairly straightforward. So dysgerminoma, this is frequently tested as the female equivalent of a seminoma, and one of the most important details is that dysgerminoma can kind of show up in questions as a pulling sensation in the groin. For some reason that detail is preferred, but they'll mention a pulling sensation in the groin. That tends to refer to dysgerminoma. Not that should be overly specific for this tumor, but it is in questions. And a detail that is frequently not memorized by students, but will clinch the diagnosis, is LDH as a tumor marker. So beta-HCG is pretty non-specific. You see it in mixed germ cell tumors, choriocarcinomas, other types of tumors. But if they mention increased LDH, that is reflective of dysgerminoma. So we say the female equivalent of seminoma. Now, seminoma in a male, for instance, you tend to see the placental alkaline phosphatase. That's the characteristic tumor marker that will clinch the diagnosis. And for dysgerminoma, you need to remember LDH, so lactate dehydrogenase, as the characteristic tumor marker. Now, choriocarcinoma, as we've discussed, is a tumor of trophoblastic tissue. Trophoblast is a component of the placenta, and this will show up in questions as placental tissue. If they're referring to choriocarcinoma, which you can make the diagnosis through the vignette, and then they'll ask you that this is a tumor of what kind of tissue. And sometimes students will just remember trophoblastic tissue without really giving thought as to what that even means. But trophoblastic tissue is that of the placenta, so it's a tumor of placental tissue. And you need to remember that if they do a biopsy of the tumor itself, that chorionic villi are not present. Okay? So recall that choriocarcinoma can classically occur secondary to hydatidiform mole, more commonly a complete mole, and this will be a progression from the invasive mole. So you have this hydatidiform mole, it becomes invasive. Now, if you do a biopsy of the invasive mole, you'll see trophoblastic tissue with chorionic villi. So if they tell you in the vignette, biopsy of a suspicious lesion shows chorionic villi and trophoblastic tissue, or they could see chorionic villi and placental tissue, they're referring to an invasive mole. But if they tell you biopsy of suspicious lesion shows placental tissue or trophoblastic tissue, and they explicate the fact that chorionic villi are not present, and they'll always be explicit regarding this point. If they tell you chorionic villi are not present, then the answer is choriocarcinoma. All right, and invasive mole will be an answer choice. And choriocarcinoma tends to liberate large amounts of beta-HCG, and you also see bilateral thecal lutein cysts secondary. Yolk sac tumors, also known as an endodermal sinus tumor. This is classically the answer for children under the age of 3. Sometimes you can just see the vignette and they'll say, a 1-year-old girl, and you just know right away it's yolk sac tumor. Obviously, you want to read the question, but sometimes you just see the childhood vignette. If you knew it was leukemia, you'd think ALL for a child, or a bone tumor, you'd think Ewing's. So these various childhood tumors, and if they're referring to an ovarian neoplasm and it's a baby or an infant, think yolk sac tumor is highest yield. And the major point, now this is something many students will get wrong, is that AFP, so alpha-fetoprotein, is elevated as the tumor marker for yolk sac tumor. Okay? Alpha-fetoprotein is elevated with yolk sac tumor, but if they also mention that beta-HCG is up, the answer is not yolk sac tumor, it's mixed germ cell tumor. Now, if they tell you in the vignette that there's increased AFP and beta-HCG, most students will see the AFP and just automatically think yolk sac tumor, okay, but it's wrong, and they won't even realize they got the question wrong. If they mention increased AFP, but also a concurrent increase in beta-HCG, the answer is mixed germ cell tumor, okay, mixed germ cell tumor, not yolk sac tumor. So AFP is up with yolk sac tumor, but you won't see a concurrent increase in beta-HCG. And recall that AFP is also the tumor marker for hepatocellular carcinoma, hepatomas. Okay, so AFP isn't necessarily specific for yolk sac tumor. Sometimes they like to ask you what other cancer would have the same tumor marker, and it's hepatocellular carcinoma. Or vice versa, they'd mention an HCC and then want you to know that yolk sac tumor has increased AFP also. So, Schiller-Duval bodies are the histological pathognomonic characteristic of yolk sac tumors. They're not the highest yield, but yet again, if the vignette is relatively vague and they mention that a biopsy shows these primitive renal, these primitive glomerular-like structures, the answer is yolk sac tumor because these are Schiller-Duval bodies. Now, Krukenberg tumor is a USMLE favorite. It's honestly one of the highest yield ovarian neoplasms that they'll ask, which in a sense isn't a true ovarian neoplasm because they're gastric metastases, okay? So it'll give it away sometimes that it's bilateral, and bilateral should hint that it's not a primary focus, unless we're talking serous cystadenoma or serous adenocarcinoma. Those are the bilateral ones. So if they mention bilateral, it should go off in your head that Krukenberg tumor is a possibility. Sometimes they'll mention in the vignette that there's an enlarged left supraclavicular lymph node, Truccio sign, Virchow's node, okay, so they like that as an indicator for gastric cancer, and they'll mention the mucinous characteristic, the signet ring cells of the Krukenberg tumor. You know, rarely will they have you actually need to identify this histologically. It has been known to have been tested, though, where you see this picture and the clear histology. Okay, so you see these large, clear-looking, they almost appear adipose in a way, but it's not adipose tissue, it's mucinous. So these are signet ring cells, and these are characteristic of Krukenberg tumor. So these are gastric metastases. They spread to the ovaries hematogenously. So for the flash quiz, what is/are the tumor markers for dysgerminoma? Recall that LDH and beta-HCG are the two tumor markers for dysgerminoma, and most notably remember LDH.